Hey everybody, what's going on? Lecky coming at you on another little edition here of some great news you can use, content driven by you, right? If you have questions about what we're talking about today, all things colon cancer awareness month, it's all of March. This is your time. We brought in an expert to help you out with a lot of this, and I apologize for a little glitches. You know, what are you going to do? It's technology, little virtual world. But hey, somebody I want you to meet is Dr. Jeff Costanza in the house with us today. How's it going?
How you doing, Ryan? Good to talk to you.
Yeah, well, listen, I know obviously you are busy and we are catching you in this break between procedures, but you know what? Throughout the month of March, a lot of buzz, a lot of attentions, especially from gastroenterologists just like you on March as Colon Cancer Awareness Month. So I think as an expert and somebody who's been in this field for a number of years, what are the biggest takeaways you want people really to have the lights go off when we think of March as Colon Cancer Awareness Month?
Sure. So every year we have this, Colon Cancer Awareness Month, and we like to try to make people aware that this is a cancer that's pretty common, and more importantly, it's a cancer that we have really good methods of detecting early. And once you do detect it early, there's a lot of really good treatment options. So it's a very treatable cancer when detected early. And when we apply these sort of screening methods sort of broadly for a lot of people, we can reduce the rates that colon cancer occurs in this country.
All right. And obviously, we're going to get to more of the facts, the screening ages and stats as some more people maybe hop on and ask some of these questions. But something I wanted to ask you, there's been a lot of buzz, a lot of PR people now are pumping this out for this month, for all of March, something known as virtual colonoscopies. A lot of people are buzzing about this, and I think there's some confusion because right now, during the pandemic, in the virtual world, a lot of people are doing everything virtual, but virtual colonoscopies isn't really what you think. So what is that, and how do those work compared to the old school ones where you have to drink the juice and come in on the table?
Sure. So virtual colonoscopy is a real thing, and it is not something that is done over Zoom or over the computer. So this is a very valid, widely accepted method of screening for colon cancer. What it's basically done is it's done in a CAT scanning machine, and they put a little catheter in your rectum and they put some air in there and they take a lot of little pictures to look at the lining of the colon. So it's done without the need for sedation. It's a little bit, it's quite safe, and it's a very viable method of screening for colon cancer. But generally, it's done with a CAT scan. It's not done over the computer or with a camera. The flip side of that coin is that a lot of the reasons that people would be interested in it would be that they don't want to take the laxative prep that we always have to give people for a colonoscopy. It is still required to take the laxative prep even prior to a virtual colonoscopy. And also it's done without any anesthesia. So there's some general discomfort that's associated when they put air into your colon because you're awake the entire time.
Yeah, it's so interesting. And I'm really glad you answered that question about the prep that goes into it. So right now, and what is your thoughts as a gastroenterologist? I think when people are worried about obviously having to be maybe put to sleep for a regular colonoscopy, you see a lot of buzz. There's even commercials on television now, Jeff, that, where people can actually send in stool samples, right, to get screened for colonoscopy. As an expert, would you ever advise that to somebody to kind of send in your home sample to get checked out for colon cancer? Or what are your thoughts when people bring that up to you, patients?
Sure. So, we could do one thing at a time. So stool testing is a common thing that we deal with, right? And it is an option, and it's a valid option. But the important point is that it depends on the patient, right? So if you're considered an average risk patient for colon cancer, which means you don't have any family history or any personal history that would sort of set off alarm bells, doing a home-based stool test, and what they do is they look for DNA molecules that are abnormal in the stool, is a perfectly reasonable way to screen for cancer. That's recommended approximately every 3 years. Now, it's sort of a little uncomfortable to have to submit a stool sample into a box, but it's pretty accurate, it's pretty safe, and for people who don't want to undergo anesthesia or don't want to undergo any invasive procedures for whatever their reasons may be, this is also a perfectly reasonable option. The point is this: we have multiple options available that are very safe and really very effective to screen for colon cancer, and this is another one that's perfectly valid.
Now, would you recommend that might be for somebody who doesn't have as much high risk for colon cancer in their families at a younger age? And then you say, hey, if you hit this age, you still need the old school colonoscopy. How do you navigate that a little bit more?
Right. So it depends upon the patient's personal risk factors, right? So an average risk patient, by that I mean patients with no family history of colon cancer, would be okay to be screened using only stool testing. And the common one that you see on TV with a box that has arms and legs and a smiley face is called Cologuard. That tests for DNA in the stool. So that's fine to do under the assumption that if it ever comes back positive, then that does have to be followed up with a colonoscopy to try to find out why it became positive in the first place.
And obviously, I know, Dr. Jeff, with this month alone, you get a lot of questions, and even there's still some confusion out there when certain guidelines were changed for screening and ages. So can you break that down and walk us through that, like regarding family history, ages you should consider getting screened, the whole 9 yards?
Sure. So there are two sort of players here in terms of the people who set the recommendations. The GI society, so the professional bodies in my line of work, recommend routine screening starting at age 50. Importantly, that actually decreases to age 45 in African Americans, because we do know that this colon cancer does happen to be positive more commonly in African Americans. So we start screening African Americans at age 45, and then non-African Americans at age 50. What changes is that if you have a first degree family member, and by that I mean a sibling or a parent who has colon cancer that was diagnosed under the age of 60, if that's the case, then the screening recommendation changes to starting at age 40 or 10 years before the age of diagnosis of your family member, whichever comes first.
But as you mentioned, it's really immediate family, right?
It's immediate family. So if your second cousin once removed and your mom's uncle or whatever had colon cancer, genetically speaking, that does not increase your risk. What can, and it's a little beyond the scope of this interview here, but if you have multiple family members across multiple generations, that can be an indication that your risk will be higher. But if it's just one isolated person, or if that person is greater than the age of 60, that really will not increase your personal risk of colon cancer.
Let's talk about just some of the prep. Has anything changed over the past few years in preparing for a colonoscopy? I mean, I know sometimes people are like, oh my God, I got to drink the juice. Is that still the standard?
So the quickest answer to that question is yes. We try our best to make it more palatable on patients. So what we do is, so the nightmare scenario, right? The classic preparation for a colonoscopy is 4 liters, which is a gallon of liquid. What we do in my line of work to try to make it a little bit easier on the patient is that we split that dose in half, and you basically have 2 separate occasions to drink it. So you drink half of it in the late afternoon, early evening, and then the other half of it several hours before your procedure. That way you're not drinking 1 gallon of liquid all in one sitting, because people get full and nauseated and things like that. It's very common to have side effects. There are multiple different options for preparation. Some of them have less volume of liquid involved. Usually these things are driven by insurance companies. They can get a little expensive, but we have multiple different options of liquid to drink. Some of them do use pills, but importantly, because people ask me about this all the time, can I just take a pill to clean my bowel out? And the answer is not really. There are multiple pills, and you still have to flush it down with a lot of water. So there's really, at this point, no 2 ways around it. We try to make it easier by limiting the actual volume of liquid that people have to drink at one time.
Gotcha. Kind of walk people through the process, I guess. If we're really encouraging people to consider getting screened, if you meet certain guidelines and all of that other stuff, how long does the prep usually last? How long can you not have food for, the procedure itself, and maybe how long are you under for?
Sure. So the hard part for patients is the day before, okay? Usually the most challenging part, other than the laxative prep, and again, I told you what we do in my line of work to try to make that a little bit easier on the patient, is the lack of solid food, okay? So we generally say that you have to have a liquid diet for only the day before your procedure. You can't eat or drink anything red, because that could potentially look like blood when we do the procedure, which makes us nervous. So only the day before, for the most part, you're drinking only liquids. You're eating soup and Jell-O and things like that. Then you take the laxative preparation as prescribed, okay? The procedure itself happens usually in the morning because people are hungry. It's a very standard, very safe and straightforward procedure under most circumstances. So once you give the anesthesia, the procedure itself takes around 15 minutes or so. There is some variations because not everybody's built the same, but it's usually a 15-minute procedure. It's done under anesthesia. It's completely without pain. It's completely safe. And then you're awake essentially immediately after the end of the procedure.
All right. And Dr. Jeff, for people who might have hopped on late, what is the average age, again, that you recommend somebody to get a colonoscopy?
Right. So the average age based upon the GI societies is starting at age 50, unless you are African American, and then it's 45. If you have a first degree family member, meaning sibling or parent, that has colon cancer diagnosed below the age of 60, you start getting screened at age 40 or 10 years before the age of their diagnosis.
You know, something interesting, just in my line of work, one time we actually spotlighted a girl who was 17, 18 years old when she was diagnosed with colon cancer. So what are some of the signs, right? If most people are like, hey, I don't have some of those, I guess, you know, family members who had colon cancer, and I don't have to get screened till I'm 50 and blah, 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 blah. What are some of the signs, warning signs that people should really pay attention to or see a gastroenterologist if they're experiencing them? Because even though this usually affects people like, 40 and up for the majority of folks, and that's what statistics and research shows, you know, it still could affect young people. As I said, we've done a story on somebody who was 17, 18 years old who had colon cancer. So what are the signs that we should look out for in our own health that should tell us time to see a GI specialist?
Right. So that's a really important question, because that's something that I get asked quite often, right? Doc, I don't have any symptoms. Why should I bother getting screened? So the truth is that, you know, colon cancer in its early stages really wouldn't even give you any symptoms. Okay. So by the time you would have symptoms of colon cancer, it's usually pretty advanced, okay, potentially even spread to other parts of the body. So a reason to always see somebody in my line of work would be bleeding in your stool, okay? Any unexplained change in your bowel pattern, the frequency, the consistency of your stool, visible blood, any abdominal pain that you can't really otherwise explain, and then certainly weight loss that you are experiencing and not trying to do, okay? So unintentional weight loss, abdominal pain, visible blood in your stool, or an unexplained change in your bowel pattern is definitely a reason to see somebody in my line of work, okay? Because the truth is that the majority of times you have, you know, colon cancer on the early stages, you really would not have many symptoms. Which is, again, why we do this on a routine basis once you reach a certain age.
And is it yearly once you reach a certain age, to recap all of that?
So that depends. The reason to do yearly colonoscopies, there are really not many. There are various conditions of the colon that will increase your chance of colon cancer. And that's maybe when you want to do yearly. But generally, it depends upon the results of your own exam and your family history. So if you have a colonoscopy at age 50, and you have no family members who have colon cancer, and they find nothing in your colonoscopy, then you can wait 10 years. Okay, generally, if you have a polyp that's removed, and we can talk about that in a minute, Ryan, it usually shortens that interval to every 5 years. There's always reasons to shorten that interval even more, but the standard is either every 5 or 10 years, depending upon what they find.
All right, and if a polyp is discovered, kind of explain that aspect.
Right. So what a polyp is a growth of the lining of the intestine. When I say colon, I mean large intestine. They're synonymous, right? So a polyp is a growth of the lining of the large intestine. The reason it's important is because over time, now not all polyps are created equal, but many polyps can grow and grow and grow, and eventually that's when they become cancer. The reason that we do a colonoscopy is because the majority of times that we find polyps that will eventually grow into a tumor, we can remove them right on the spot. So, you know, if you see something, if it looks like a little growth of the lining, we have instruments that we can remove it, and therefore you completely remove the potential for that spot to grow into cancer. So a polyp essentially sort of is a precancerous growth of the lining of the large intestine. That's exactly what we look for.
So much great content. I want to bring in some of the Facebook questions that people are asking, and we'll fly some of those in. You know, I think an interesting thing is always bringing someone with you to the colonoscopy. Somebody, Joan, actually weighed in and asked, why aren't there more recovery rooms or more options for people who have no choice to drive themselves? As a doctor, physician, what's your advice to people, you know, who are busy, their family's busy? I mean, have we gotten to that point yet where you can come get a colonoscopy, maybe rest for 30 minutes and then drive home? Or why do you not advise against that if that is the case?
Right. So to answer Joan's question is that generally when we provide anesthesia to a patient during a colonoscopy, we don't recommend that they drive that day. Because although the anesthesia will be worn off in your system pretty quickly, you still may be a little groggy and things like that. So medically and legally, we don't advise that you get behind the wheel of a car. which is the rationale behind having a family member come to drive you, assuming that you have some residual leftover effects of the anesthesia. We talked a little bit before about virtual colonoscopy. Now, this would be a potential option where, say, for example, I can't get a ride, I can't take a day off of work, I really have no options, I cannot go under anesthesia. Well, that's when you could potentially do a virtual colonoscopy, because that is done while you're awake. And you could basically get off of the table and get in your car and go about your business. But with a standard colonoscopy, it's done under anesthesia, and medically, we don't allow patients to drive until the next day.
And I know you mentioned virtual colonoscopy, and that's using CAT scan technology. It's not over Zoom where a doctor kind of tries to look and see what's going on. I think we want to stress that in this virtual world. But I guess, are you seeing an increase in virtual colonoscopies, Dr. Jeff? I mean, is your practice doing those, or are they starting to become something more popular in the state of Pennsylvania?
They are becoming more popular. And again, it's usually kind of an individual decision, right? So it's like I said before, it's people who don't want to undergo anesthesia for whatever reason, or they can't get time off of work, or they can't find a ride. So that's a totally viable option. There are some technical reasons from my side of the job to do a virtual colonoscopy. So for example, if a patient has had a lot of abdominal surgeries and they have a lot of scar tissue in their abdomen, that can make doing a colonoscopy extremely difficult, and even impossible sometimes. So that's when a virtual colonoscopy would be a great way and safe way to look at the remainder of the colon that a standard colonoscopy couldn't get to. So the bottom line is that there are many reasons to order the virtual colonoscopy. It's tailored a little bit to the individual, and it is becoming a little bit more popular because people are aware of it more as options.
All right. And one question I got from Nancy that I think is something a lot of people can relate to, and you don't have to answer this now if you want to research a little bit more, for the need that's out there for people who know they should get a colonoscopy, but maybe they don't have insurance. Maybe they lost their job during COVID, or they just can't afford the copay. Is there anything, I mean, what do you advise patients when, that topic's brought up? I mean, it's tough for a lot of families.
It's really tough. And we do come across this from time to time. Now, I mean, I think you would have to have not only a discussion with your insurance company, but also maybe with somebody on the administrative side of the GI office. So occasionally, when the doctor orders the test, if they don't use the appropriate code from an insurance standpoint, okay, the insurance companies will reject it. And what they would basically do is say, well, if you are doing the colonoscopy for these reasons instead, bleeding or change of bowel habits or weight loss, then we will pay for it. So it may be something as simple as just the reason why you are getting the colonoscopy done. Obviously different insurance companies have different co-pays and deductibles and things like that. So there's probably a lot to that, but I would encourage you to at least maybe put a phone call into your insurance company and then see if anybody from the doctor's office can figure out a way, because this is something that we have to navigate from time to time. Insurance companies can sometimes make things a little more complicated.
And Dr. Jeff, I know you mentioned people who might be African-American in their 40s, right? They're encouraged to get screened earlier because colon cancer can affect them maybe sooner than other ethnicities, and all are affected differently. I guess, what is your advice in general when it comes to men and women? Are men more predisposed for colon cancer in general across the board versus women, or what have you found in your practice?
There are some differences. So some studies have shown that women tend to be a little bit more likely to develop colon cancer, but it's usually pretty uniformly distributed. They've definitely studied differences in ethnicities, African Americans, Hispanics, Pacific Islanders, Alaskan Natives, things like that. We do see ethnic differences in how common colon cancer is. There are gender differences, but they tend to be a little bit smaller. And again, though, you have to kind of look at the persons. There are all their risk factors for colon cancer, such as obesity and family history and things like that. So again, you always have to kind of get a sense for exactly what the patient's personal risk factors are.
All right. And as we get ready to wrap this up, Dr. Jeff Costanza, who's actually from the Clark Summit area, just, I guess, your final thoughts just on this month alone, because obviously colon cancer affects people year round all the time. What would be your message to somebody who's been putting off getting screened, getting a colonoscopy? I mean, it's really, I think, what do you want to hit home with all of that?
Right. So it's nothing to be afraid of. It's a really common procedure. It's very safe. It's painless. And the whole point is that you can find a potentially life-threatening condition at an early stage when you can treat it completely. So this is if you even find an early onset colon cancer with the proper treatment, depending upon a couple of things, you can use the word cure. So patients sometimes worry about the prep. We can navigate that. Patients worry about whether or not there's going to be pain. There really isn't. It's a really commonly done procedure that really should be made available to anybody who qualifies, because it can easily and effectively prevent a potentially fatal disease.
All right, I'm just looking, so much great information before we wrap this up. Just a few other topics here. I know this would be tough. Gregory Fleck asked the question, how many people die from colon cancer? But I mean, that's probably tough to narrow down.
Yeah, I mean, the exact number, I couldn't quote you off the top of my head. I do know that colon cancer in this country is the third most commonly diagnosed cancer, and also the third most common cause of cancer death. So I believe that lung cancer is the most common. There are a few other, but it's common, not only common to be diagnosed, but common to cause fatality. I want to say the annual cancer deaths are somewhere under 100,000, but you need to take that with a grain of salt. Ryan didn't give me enough time to do the research before we had this interview. So
yeah, I didn't expect you to give me the exact number. I guess just because as a gastroenterologist as well, and I told people, if you ever have any questions for a GI doc, now's the time to ask. Debbie Heim asked the question, is popcorn bad for somebody who's had diverticulitis?
Okay, so I regularly get this question, okay? We're a little off topic here, but what diverticulosis is there are little bulges and pockets that form in the colon lining. They usually form under conditions of high pressure, such as constipation and things like that. Believe it or not, one of the elements that also helps create this problem is how we sit on the toilet. So in countries that squat to poop, India, China, you don't have as many people with diverticulosis, right? That's a separate issue. What diverticulitis is when one of those little pockets becomes blocked up and inflamed. Now, classically, people will say, well, if you eat popcorn and peanuts and seeds and nuts and things like that, you'll block one of those things up and you'll cause it to be inflamed. I need to be clear about this. That has never been proven in any scientific literature. So I make it a point to tell my patients that have diverticulosis that they can eat whatever they want, that they do need to get adequate amounts of fiber in your diet to prevent those things from getting bigger and developing anew. But there is no direct link between eating peanuts and getting flares up of diverticulitis.
There you go. Knowledge bomb for Debbie Heim, thanks to Dr. Jeff. And before we wrap this up, I know you're part of Eastern Pennsylvania Gastroenterology and Liver Specialists. Do you actually see an uptick in colonoscopies in March versus other months, or is it just business as usual?
I think we are very busy. So, we are commonly booked out for 4 to 6 weeks at a time. So, I could tell you, me personally, that I have very few availabilities until almost May. So we do see a lot of it. I suppose the uptick is there, but it's probably pretty small because we're always very busy.
And I know out of Eastern Pennsylvania Gastroenterology and Liver Specialist, Dr. Jeff Costanza, you work out of the East Stroudsburg area, in case people are wondering, in case they're like, I saw this expert, I want him to do my colonoscopy. I have to say, I haven't had a colonoscopy because I'm not in any of those factors yet. But the thing is, Dr. Jeff, I remember one time I had heartburn for a few days and I was panicking because I never got heartburn. And I went to see this guy and he was a rock star. And it was also the first time in my life I ever had anesthesia. And you know me, I can never shut up most times that, I've interacted with you and some other folks, but you're like, why are you so quiet? I was a nervous Nelly, but it was actually the most painless, smooth procedure ever, and also the best nap I've ever had. And I was only out for 10 minutes. I was like, how long was I gone, Dr. Jeff? 8 hours? You're like, calm down. You were asleep for 10 minutes.
Yep, I remember that day well. Ryan, I've known you for a long time, and I have never seen you that nervous. And you did really, really great. And I think the important thing is you can tell your viewers that there's really nothing to be afraid of. It's a comfortable, painless nap.
Yeah, definitely. All right. It looks like for the most part, we caught most of everybody's questions that they had. And we really hope that a lot of people will share this because I think there's a lot of fear around getting a colonoscopy or just, what ages you need to have it done. And Dr. Jeff kind of boiled it down and explained it all. I'm just scanning if we had any last minute questions. But for the most part, I think we covered it all. The biggest ones were ages regarding screening. And are there any resources or places that you have advised your patients to say, hey, if you have any more questions about this or colonoscopies in general, here's a great site that you would recommend as a physician?
Sure. If you go to gi.org, there's some patient materials there. You can also get it from the National Cancer Institutes, the American Cancer Society, and then the CDC actually also has pretty patient accessible general information about these procedures.
All right, the one and only Dr. Jeff Costanza from the Clark Summit area, and everybody else too. Thanks for sharing your questions and talking about this. And I'm going to leave you with this, because when I talked to some people and said we were teaming up with a GI specialist, they're like, I know this is random and I don't feel comfortable asking. So I'll ask the question for them. How many times a day should you have a bowel movement? What is the norm? And I know you get that question as a GI specialist, but you know what? We're going to go there because some people who didn't feel comfortable asking that on Facebook, I will ask for them. What is normal flow for a person?
So that's a good question with really not a straightforward answer. Okay, so everybody's different. Some people go 3 times a day. Some people go once every other day. The question becomes, is the frequency of how often you are pooping causing you problems? Are you having pain because you're constipated? Are you waking up in the middle of the night because you're having diarrhea? So that's when it becomes an issue. Otherwise, how often, it really varies. I mean, I have patients who go, once a week and they have no problems. They have no bleeding, no pain, whatever, and that's just how they're built. So you have to kind of take a step back and say, well, just because I'm not hitting a certain number, then I'm not normal. It may be normal for you. You have to evaluate it in the broader scope of, are you having problems or symptoms because of it?
All right. Really appreciate it. I had to go there because some people are like, wait, I want to ask him this, but wait, I don't want to go on Facebook and ask that. I'm like, I will. It's fine. I'll get you the information. All right. So Dr. Jeff Costanza, thanks so much for your time. I know you have other procedures today. It's going to be obviously busy for you. In March, Colon Cancer Awareness Month, the bottom line, get screened. He shared some of those resources as well. And I appreciate everything as always.
It's good to see you, Ryan.
All right, everybody, take care.